All right, guys, floating ventilator guys back. So a lot of questions, asks, and feedback to go over Avaps. So what does Avaps stands for? Average volume assured pressure support. So essentially it's an adaptive mode, and you all know how I feel about adaptive modes, that we dial in a total volume that we want, and we dial in an EPAP, and we dial in a minimum pressure right here and a maximum pressure here. So we're telling the ventilator that we want a certain amount of volume at a certain rate, and we're willing to go down to a X level of pressure, and we're willing to go up to an Y level of pressure. So here it's set to a minimum pressure of 12 and a maximum pressure of 20. So essentially we're targeting some minute ventilation that we want to assure that the patient will get. This mode is really for the outpatient world. So people who are sleep doctors, who are prescribing for people with nocturnal hypercapnia from either neuromuscular disease or obstructive sleep apnea or obesity and hypoventilation syndrome or like COPD. There is no evidence for sort of the in-hospital acute sick patient. Furthermore, there's evidence from a 2015 study that I list here that there is an increased mortality when you use adaptive servoventilation, so this mode, in patients who had central sleep apnea as well as heart failure, the EF less than 45%. That's a pulmonary board question just for all my pulm board takers out there. So if you're an outpatient and you have central sleep apnea and you have an EF of less than 45%, you're not on this mode. So I'm not really sure where it became sort of in vogue to use this in the hospital. I personally don't use it. If I have a patient who's hypoventilating for some reason, number one, I try to figure out what's the underlying cause. So normally we group hypoventilation into like kind of can't breathe, won't breathe. So I can't breathe because I have a neuromuscular disease, or I won't breathe because I have a bunch of narcotics on board, let's say, for example. So if I have a patient that's not breathing and I don't have an explanation, I tend to find out why the patient's not breathing. I'm not comfortable just sort of slapping them on AVAPs and guaranteeing a minute ventilation. Furthermore, as a general approach, I am not one to, if a patient is critically ill, I don't want a machine doing the thinking for me. So much like how I don't particularly like PRVC, because when we choose these adaptive modes, AVAPs, PRVC, VC plus, or VC with autoflow if you have a Draeger, you're giving up control to the machine. And I don't like to give up control to machines when I have a critically ill patient. I like to do the thinking. And this is because of how I was taught by my friend and mentor, Arturo Federico Dio.